So I want to talk a little bit about precision oncology for metastatic castration-resistant prostate cancer. I know that's all a term that none of us like to hear, but I think it's something that we're seeing a lot more of now because of the advancements in treatment for prostate cancer and other cancers. A lot more people are living longer and getting to the point of castration resistance. And of course, the big thing is, what do you do when you get there? The standard therapies don't typically work. So I thought that we just focus on this because I'm sure everyone else here has a lot of experience with standard care and with prostate cancer treatments and so on. So I thought I'd just cut to the chase and focus on this one subject. But I'm happy to share our videos with you. We have a whole website called The Cancer Guy. So if you Google The Cancer Guy, you'll see our website, and I'm also going to provide a link for you here. So what is metastatic prostate cancer? It's basically a cancer that shows resistant to standard ADTs and ARPIs. So ADTs is androgen deprivation therapy. That's reducing the testosterone. And then ARPIs are androgen receptor inhibitors, basically enzalutamide, all the lutamides. And what they do is they bind onto the androgen receptor and they prevent testosterone from binding it. And as you probably know, prostate cancer, for the most part, is an androgen receptor-driven cancer. So I'll refer to the androgen receptor as AR. So some of the mechanisms that result in androgen receptor resistance, which is basically what castration resistance is mutations in the androgen receptor itself, where it starts signaling by itself. And then high heterogeneity. And heterogeneity refers to variations between the individual tumor cells, both within a tumor and amongst the various tumors in the body. And basically what it means is, some of the tumors are being triggered, or some of the cells are being triggered by one thing, and other cells are being triggered by something else. Heterogeneity is something that naturally happens as a cancer progresses. You get more variation between the tumors, and it becomes much harder to treat because then one drug is only going to affect a small percentage of the tumors, and it's not going to affect all of them. But one of the things that is most concerning that we're seeing now more frequently is a switch to a neuroendocrine subtype. So neuroendocrine is a different type of cell than a prostate cell. It's a type of cell that occurs throughout the body. But what can happen is prostate cancers, after they've been treated for a while, can switch to this neuroendocrine subtype. So it's like they're trying to change how they look in order to hide from the immune system and hide from the treatments. And so they're referred to as transformed neuroendocrine prostate cancer. And that little T there stands for the word transformed. So we're going to talk about the tools for precision oncology, but specifically in the context of metastatic castration-resistant prostate cancer. Does everyone know what tumor DNA sequencing is? I'll explain it. We've got a bunch of videos on that, but basically it's where you take a sample of the tumor, such as a biopsy, and then you look at the genes that are in that are associated with cancers, and you look at what genes are mutated in there, and then you have drugs that target those specific mutations. So in the last 25, 30 years, we haven't really made any new chemotherapy drugs. Chemotherapy drugs are a general type of drug that basically interferes with the ability of a cell to reproduce. But unfortunately, it does that to all cells. It's not just cancer cells. So when you take chemotherapy, you're going to affect your normal cells too. They're going to get damaged by the chemo too. Also, chemo is only effective when the cell is trying to reproduce. And so the chemotherapy drugs are active in your body for a very short period of time, a couple of hours, and then they stop working. And if they didn't, they would kill you because your body is constantly trying to reproduce cells, immune cells, skin cells, and so on. And so therefore, chemotherapy can only be given in limited doses because it actually does cause a lot of damage. And once again, it's not a cure. It only affects the tumor cells when they're actually actively reproducing. It interferes with their ability to separate from each other. We're also going to talk about HER2 IHC testing, that refers to immunohistochemistry. And then we'll talk a little bit about tumor RNA expression testing. So tumor DNA sequencing for metastatic castration-resistant prostate cancers. There's two things we like to look at in tumor DNA sequencing for prostate cancers. Number one is, are there mutations in genes that will result in benefit from a class of drugs called PARP inhibitors, PARPIs? And then additionally, we're going to look at how high tumor mutation burden affects this. And I'll explain everything once we get to it. But first, a little bit about PARPs. PARP inhibitors are a drug. They're a targeted drug. And what they do is they trap this gene called PARP1 at the site of a mutation. So whenever we get mutations in DNA, we have about 50 or 60 different genes that are constantly repairing it. Think of them kind of like the road crews that repair the roads around your neighborhood. Whenever there's a broken sign or something breaks, the road crews out there fixing that. Well, tumor suppressor genes are the same way, and they actually are constantly repairing DNA damage. And DNA damage happens all day long, every day, so it constantly needs to be repaired. PARP is one of these genes that fundamentally is involved in this, and it has a unique way of working. But when you take a PARP inhibitor, what it does is it tricks the gene into staying attached to the DNA. So normally the PARP gene attaches to the DNA, repairs the mutation, then it leaves. What PARP inhibitors do is they make this gene PARP attached to the DNA, and it gets stuck there, kind of like it's glued there. And this results in increased DNA breaks called single-stranded breaks. Single-stranded breaks are, so our DNA has two strands. One goes one way, the other goes the other way. It's called double-stranded DNA. And when you create breaks in one single strand, then they can be fixed. But what happens is if you have both strands broken, then it's really hard to repair. And, it requires a special type of machinery that is not always working. So what these PARP inhibitors do is, instead of allowing the PARP1 protein to fix the DNA, it causes them to break the DNA even more. So it causes it to, do a worse job. And I have a nice analogy for this. One time I had this nice new car, and my girlfriend, who was a little naive at the time, hadn't had a lot of experience with cars, she said, "Listen, I'm going to go out and I'm going to wash your car. It's really dirty. It really needs a good cleaning." I said, "Well, thank you very much." And so I went out there a couple of hours later, and I saw that she had actually used steel wool on the car. So while her intention was great, just as the PARP gene has good intentions in fixing DNA, the PARP inhibitors cause it to do things it's not supposed to do, and that is to damage the DNA to the point where it can't be repaired and the cell dies. However, in order for PARP inhibitors to work, you must have pre-existing alterations or mutations in a class of genes called HRR genes. These are the genes that are called homologous recombination repair. And so if you recall from the previous slide, I said because the PARP attaches to the DNA, it causes these single-strand breaks that then create double-strand breaks. Well, homologous recombination is the only way our cells can repair double-strand breaks. They're really hard to repair, and these homologous recombination genes are the only ones that can actually do that. So I'm going to show you a slide on homologous recombination genes and their occurrence in metastatic castration-resistant prostate cancer. So these are the ones. These are all homologous recombination repair genes. There's a whole bunch of them. CHEK2, ATM, BRCA1, PALB2, RAD51. RAD means radiation inducible, so it repairs DNA damage caused by radiation. And you can see where we have BRCA2. So the BRCA genes are the most prominent DNA repair genes. And they were first recognized in women that had early breast cancers and ovarian cancers. And they found that if they had an inherited BRCA2 mutation, they had a really high risk of all kinds of different cancers. That was found many years ago. Now we're finding BRCA2 mutations in all kinds of cancers. But if you look at the ratio here, 44% of men with prostate cancer, with castration-resistant prostate cancer, have BRCA2 mutations. ATM, 13%, CHEK2, 12%. So the vast majority of men with metastatic castration-resistant prostate cancer have mutations in these genes and therefore would benefit from PARP inhibitors. So what about PARP inhibitors? Are there any approved? There's 4 different PARP inhibitors approved for prostate cancer right now. They're all approved for metastatic castration-resistant prostate cancer, and these are FDA approved. So olaparib was kind of the first one. It was approved in 2020 for metastatic castration-resistant prostate cancer who have genomic alterations in specific HRR genes. And those, it's basically specific to BRCA mutated metastatic colorectal cancer patients, which is almost 50% of patients. And it's FDA approved for a androgen receptor inhibitor called abiraterone. I'm sure some of you have heard of that before. And it's combined with abiraterone. And then we have rucaparib, which is a newer one. It's also approved for metastatic castration-resistant prostate cancer with mutations in BRCA1 and BRCA2. Then there's talazoparib, and that's approved in combination with enzalutamide for patients with HRR genes in metastatic castration prostate cancer. And then also niraparib. It's also approved with abiraterone. So I just want to go over the data for some of these trials that showed why these drugs are so useful for metastatic castration-resistant prostate cancer. And if you're a Canadian, you're probably saying, well, I've never heard of these before. Why hasn't my doctor talked about these? And, that's a great question. For some reason in Canada, we're really behind the 8 ball on these. I occasionally hear of doctors using PARP inhibitors for prostate cancers, but not very often. And these drugs aren't that expensive. In fact, you can purchase them from international pharmacies for fairly cheap. They're all oral. In other words, you take them orally, and you can get them approved. You can have them prescribed by any Canadian doctor. Even a GP can prescribe them because they don't have a lot of really bad side effects. In this particular study, this is called the TALAPRO study. What they did was they took men that were metastatic castration resistant and they hadn't had any treatments. So these were men that were first diagnosed right off the bat. They have metastatic cancer and they're castration resistant right off the bat. So, that's a worst case scenario. In fact, I don't think I really know too many people who've been diagnosed with metastatic and castration resistant as their first line. In this particular study, they looked at a bunch of different genes here, BRCA1, BRCA2, PALB2, ATM, a lot of the genes that we showed on the previous slide. And they wanted to look at how well these drugs worked. So I'm going to show you a side-by-side comparison. So on the left axis, we have what's called the probability of progression-free survival. What progression-free survival means is how long you can stay on the drug and be cancer-free before you get a recurrence. And so as you can see, the bottom one is, the bottom axis shows the months. And as you can see, the top one is a PARP inhibitor plus enzalutamide versus a placebo plus enzalutamide. And as you can see, there's quite a bit of a difference between these lines here. But what's really interesting is the relative progression-free survival for talazoparib plus enzalutamide. What a progression-free survival means is when 50% of the patients in a clinical trial have their cancer recur. And so you have to have a 50% recurrence before you can reach the progression-free survival. So when 50% of the patients have their cancer come back, then they mark that on the calendar and they say, okay, at 21.2 months, 50% of the patients came back, so we'll call that our progression-free survival. So progression-free survival and overall survival are statistics that are commonly used in cancer and medicine. And they were both referred to medians. In other words, they're 50% of the patients in the trial. So in this case, the progression-free survival would be 50% of the patients having recurrence. Now, as you can see from the top line or from the bottom line, that was reached probably what? At about, for the placebo plus enzalutamide, was probably reached, I think it was at 21.9 months. They reached the 50% point. But if you look at talazoparib and enzalutamide, even at the end of the trial at 42 months, still 50% of the patients have not had their disease come back. In fact, You can see here, it's probably be close to, it's just under 60%, maybe 55%, which is really quite amazing, because they still, NR means not reached. And so they had to stop the trial before half of the patients actually had their cancer return. Whereas compared to enzalutamide, you can see by itself, big difference. I don't know about you, but I know which drug combination I would want to be on. Now we'll look at the overall survival. And this is also interesting because they had to stop the trial before they got to the end. When you look at the beginning, both of the lines are fairly close together. But once you get down to the 50% mark right here, you'll see at overall, 50% of the patients in the trial died from their cancer at 33 months on enzalutamide. However, when they're on the PARP inhibitor and enzalutamide, even at the end of the trial, more than 50% of the patients are still alive, not reached, which is just amazing. Once again, this is metastatic castration-resistant prostate cancer. There's not a lot of treatment options in that situation. And so having a drug that can keep somebody alive for this long and longer than the trial was even able to sustain it is just amazing. This is another trial. This is called the PROPEL trial. And this is first-line abiraterone and olaparib. Now, as you know, if you've been on abiraterone, it's a steroid androgen receptor inhibitor, and you have to have prednisone with it. And that's part of the side effects. It's a great drug. It works really well. But, you know, the prednisone kind of increases the side effects. And they compared this to another PARP inhibitor by itself, plus or minus olaparib. And patients had no prior treatment for metastatic castration-resistant prostate cancer. They had to be taking ADT. Docetaxel was allowed, no prior abiraterone. And they didn't screen for these HR mutations because they wanted to see blindly which patients would work better. The crossover from placebo to olaparib was not permitted. Usually a crossover, when they find a trial that's working really well, they'll allow a crossover from the placebo to the tested drug. But for some reason, they didn't in this trial. And as you can see, the results here were quite staggering. And here's the abiraterone and the PARP inhibitor. Now, this is in the patients that had mutations in their HRR genes. Once again, that was that slide of genes. And you can see right here, the progression-free survival was only 13.9 months for abiraterone by itself. But when you combine it with the PARP inhibitor, it's still not reached. And in fact, at 31 months, almost 60% of the patients are still in remission, compared to only 13 months. And then in the non-HR, not as much of a difference. But what's interesting here is there was a difference. It's not huge. It's about 5 months difference, as you can see. Here's the 50% here and the 50% there. So once again, you have to have these HRR mutated genes for PARP inhibitors to work. But even in patients that don't have those HRR mutated genes, you still get some benefit. You know, 5 months, that's not too bad, 5 months of progression-free survival. You know, I know that certain drugs like docetaxel sometimes only give you like 3 or 4 months. And this is giving at least 5 months of progression-free survival. And this is overall survival. And once again, the abiraterone and the PARP inhibitor, in the duration of the trial, it was not reached. Here's the 50% line, as you can see. And you can see it's just hovering along that, maybe 55%. So at 48 months, they stopped the trial, and at least 55% of the patients were still alive, compared to what's this? Probably just under about 30%. And that didn't even make it past 44%. Each one of these little dots is a patient in the trial. And when you looked at the non-mutated HRR, it wasn't quite the same benefit. If you see here, the median was only 42.1 months versus 38 months. So not a big difference. So the take-home message here is the benefit really is only for people with HRR mutations. So now I want to go to the BCR-away trial. And so this was quite an interesting trial too, along the same sort of lines. And they did a few different combinations here. What was interesting here, and this speaks to one of the tenets of precision oncology. Precision oncology is the right drug for the right patient at the right time. And all three of those tenets need to be met because they can make a difference. And what the take-home message I wanted to show you from this trial, and this addresses the issue of the heterogeneity that I brought up earlier. If you recall, the heterogeneity was the variation within the tumor itself and in between the tumor cells, and how they have different variations. And so, one drug by itself is only going to do so much. So in this arm, what they did is they started the patients on abiraterone, and then they switched them to olaparib after the abiraterone stopped working. And they found that they got the progression-free survival was about 16 months. Then they tried it the other way. They said, okay, let's try olaparib and then when we're finished with that, when it stops working, we'll go to abiraterone. And they got the same, 16 months. So the sequence order of the drugs didn't seem to make a difference. However, when they used both drugs together, look at this, 39 months average cancer-free time for 50% at least of the patients, compared to only 16 months. This is a staggering difference. And it really shows you how multi-drug combinations are very important versus waiting and then doing a drug and then doing another drug and doing another drug. So the multi-drug combination at the same time versus sequencing, it makes a huge difference. One of the things that all tumor DNA sequencing panels do is they report something called tumor mutation burden, TMB. And basically what tumor mutation burden is how many mutations do you have per million megabases or per megabase of DNA. So DNA is a bunch of little pieces of DNA, and each piece of DNA is called a base pair. And so a megabase is a million base pairs in a row. This TMB increases when a tumor has more heterogeneity. So for example, if your cancer was caused by radiation exposure or carcinogen exposure, like from cigarette smoking, then you're likely to have high tumor mutations, a high amount of tumor mutations. What is interesting is there's a drug called pembrolizumab. There's actually probably about 13 approved drugs similar to pembrolizumab. They're called PD-1 inhibitors, also known as immune therapy. Normally, pembrolizumab and immune therapy, and we tried this right away in prostate cancers when pembrolizumab first came out. We were the first to ever use pembrolizumab, and we used it in a metastatic melanoma patient about 8 years ago. That patient is still alive and completely cancer-free today. Basically, what pembrolizumab does is it's an inhibitor of something called PD-1. I'll just briefly explain what PD-1 is, but we have some videos on this on our Cancer Guy website. Think of PD-1, Program Death 1, as it's kind of like a security card. So when you enter a locked building, you have a little security card, you flash it against the door and it unlocks the door. Think of that little security card as PD-1. So all of the cells in our body have to have this security card on them called PD-1, Program Death 1. If your cell doesn't have PD-1 on it, on the outside of it, when the immune system sees it, it's going to kill it. And so what PD-1 does is it tells the immune system, don't attack me, I'm one of you. I'm one of the body, don't attack me. So what tumor cells do is they're smart. They get a bubble of this PD-1 and they create a bubble of it around the tumor. And so like a fake bubble of this PD-1 right around the tumor. And so when the immune systems come to investigate a tumor because it's growing too fast and it's, got all of these other features that would attract the immune system, they see this big bubble of PD-1 and go, oh, this is nothing. We can just ignore it. And so they go away and leave it. Excuse me. So what pembrolizumab is it's a PD-1 inhibitor. So it's like a molecular sponge. When they inject it into your body, it's actually a monoclonal antibody. And you can tell because it says MAB at the end of the name. So any drug that has MAB at the end of the name is a monoclonal antibody. And that means it's an antibody that is designed to soak up something or get rid of something in the body. And so pembrolizumab soaks up this free-floating PD-1. And so now all of a sudden the immune system goes, aha, you're a tumor. We see you now. And then immediately the immune cells go in and attack it. And it's like a vaccination almost for your tumor. Pembrolizumab has literally cured many cases of stage 4 cancer. I can't tell you how many patients we've seen. Now, we've only had the drug around for about 10 years, so we don't know if these patients are cured forever. But I can tell you, I've had patients who have had literally 2 or 3 months to live. Their bodies have been riddled with tumors. We get them on pembrolizumab, and instantly their tumors are gone within 2 or 3 shots. The other thing is pembrolizumab doesn't have a lot of side effects. It basically just charges your immune system and gets it going and helps teach it to recognize the tumors. So normally pembrolizumab would not work in metastatic castration-resistant prostate cancer. And we did try it. We've tried it, and many others tried it. However, if you do tumor DNA sequencing and you happen to have 11 mutations per megabase, not 10, but 11, then it will work. And it will also work if you have something called mismatch repair deficiency or microsatellite instability high. What's interesting is the FDA has approved this drug for any cancer that has 10 mutations or more on a tumor DNA sequencing panel. So it's a unique feature. Not a lot of people have more than 10 mutations, but some people do. In this one study that they did, and this is a relatively new study, the reference is here, they wanted to see how this worked compared to chemotherapy in metastatic castration-resistant. And so they looked at 741 patients with metastatic castration-resistant prostate cancer, and they found these patients with a TMB of 10 mutations per megabase had a greater or more, had significantly longer time to their next treatment and overall survival. ICEs are immune checkpoint inhibitors, which is what pembrolizumab is. It's a fancy name for it, versus the taxanes. So it was a significant difference here. So this is one of the things we like to look for also in our tumor DNA sequencing. And it's a relatively simple test. You either have high tumor mutation burden or you don't. If you do, then you want to be looking at immune therapy, and not just immune therapy, but combinations of immune therapy. And that's a whole different world. I just wanted to introduce the topic to you. Now, I want to talk about something else. There's this brand new technology that's only just been discovered. It's called antibody drug conjugates. It is the biggest game changer we've ever seen in cancer. It's just incredible what these drugs do. And literally every company that was making different targeted therapies or immune therapies or whatever they're making have stopped what they're doing and are now making antibody drug conjugates. There's a couple of bits of technology that have resulted in this. Number one, it used to be hard to make antibodies. Now they can make them very easily. And you could just go to a university lab and you can have an antibody made against just about anything for about $1,500. And it takes them about a month or two. So that was never possible before. And now they've got this incredible new technology to make antibodies. Additionally, when they're coming up with chemotherapy drugs, they found these drugs that were incredibly strong. In other words, these drugs were so strong, they would kill every type of cancer cell they gave them to. Unfortunately, these drugs were so strong, they also killed the individuals or the animals they gave them to. And so they said, well, these are great drugs. They kill tumor cells, but they kill normal cells and everything around them. And so we can't use these drugs. And so they just put them on a shelf and said, let's just leave them there. I'm going to talk about one of the very first antibody drug conjugates. It targets something called HER2. HER2 is a human epidermal growth factor receptor number 2. It's common in a type of breast cancer called HER2 positive breast cancer. But what we now know is many cancers have HER2. So basically think of HER2 as a little receptor that's on there. And when the doctors test for this or the pathologists test for this, what they do is they have this stain that turns a different color when it binds to the HER2. So what they do is they just pour the stain onto the tumor slide, and then they count the amount of cells that have changed color. And they say, okay, you have a ratio of this and this and this. And so if you have a high ratio of HER2 receptors, then you are considered HER2 positive. And the HER2 scoring system is either 0, which means you don't have any HER2 on your tumors, or you have 1+, which means you have a small amount of tumor cells, under 10% or so, or you have 2+, which means you have a lot of HER2 receptors on your tumor cells, but not every tumor cell has a HER2 receptor. And then you can have 3+, and 3+ means that all of your tumor cells have HER2 receptors. So I just wanted to cover that. Now I'm going to talk about what an antibody drug conjugate is. And you really want to write this name down because it's the most amazing new technology. And these drugs are just blowing everything out of the water. So this is a tumor cell here. So right here, as you can see, number one, we have an antibody drug conjugate. So this Y-shaped thing is a universal sign for an antibody. This antibody is designed to bind onto the HER2 receptor. See this little green thing poking out of the cell? That's the HER2 receptor. So this is a prostate cancer cell that happens to have a HER2 receptor on it. Okay, so they inject this antibody into you. You see these little orange stars or circles? Those are the chemotherapy agents. However, these are chemotherapy agents that they wouldn't normally be able to use in people. So normally when you do chemotherapy, they inject a whole bunch of it into your blood. It circulates around to your body, kills everything in its path, and then your body gets rid of it. With these chemotherapy drugs that they use on antibody drug conjugates, they're too strong for that. They can't do that. It would kill the liver and so on. So what they do is they attach 3 molecules or 4 molecules. Some antibody drug conjugates have like 5 or 6 molecules of the chemo. It really depends on the antibody drug conjugate, but only 3 tiny little molecules of the drug. So a minute fraction of what would normally be injected into a person. So this is the amount that you wouldn't even see on a pin drop. So it's attached with this thing called a conjugate. And the conjugate prevents this drug from being released from the antibody and being activated until it's deep inside of the tumor cell. So what happens is this acts like a Trojan horse. Does everyone know the story, the Greek mythology of the Trojan horse? This antibody attaches to the HER2 receptor on the tumor cell. The tumor cell goes, oh, you must be something we need because you're attaching to HER2. So we're going to bring you inside. So then it brings it inside and it starts trying to break it down to see, what it's for. And in the process, it releases the chemo and it kills it from the inside out. And it only kills this cell. No side effects on other cells and normal healthy cells. This will not bind onto a normal cell. It'll only bind onto tumor cells that have this HER2 receptor. And it will not release the chemo until it's inside of the tumor cell. When they first came out with a HER2 targeted antibody drug conjugate, it worked so well in every single cancer they looked at. Every single cancer that had high HER2, this drug, regardless of the stage, regardless if it was stage 4, regardless if it was brain metastasis, this drug cleaned it up. Game changer. And so, because of that, now the drug is also referred to as T-DXd. That's just an abbreviation for its actual chemical name, trastuzumab deruxtecan. It's also known by the brand name as Enhertu. I like to call it T-DXd because it's nice and simple. So when T-DXd first came out a couple of years ago, I don't think the company really knew what they had. They thought, well, it's a new technology, we'll see how it works. But it worked so well that the FDA decided that they were going to approve it for any cancer that has high HER2, including prostate cancer. So if you go out and you get yourself tested and you find that your tumor cells have high HER2, then this drug is FDA approved for you. And when a drug is FDA approved, it's supposed to be provided to us for free by Health Canada. We're supposed to be following FDA approvals. That's called standard of care. FDA decides on the standard of care. And so if you're not getting this and you do have high HER2, then you are not getting standard of care. And our Canadian government has promised that every Canadian gets standard of care. Okay, so a little talk about this antibody drug conjugate. Because it worked so well on HER2 positive tumors or tumors that express HER2, immediately all the other drug companies started making their own antibody drug conjugates to target HER2. Right now, there's almost 1,500 drug companies trying to make better versions of T-DXd using different antibodies or different combinations or different linkers or different chemo drugs. And so right now, there's actually about 5 HER2 targeted antibody drug conjugates available. And each time a new one comes out, it's better than T-DXd. There's a new one that just got approved that works way better than T-DXd. And so that's going to be a real great bonus. So additionally, T-DXd has another trick up its sleeve. It has what's called bystander effect. So not only does it bind to the tumor that has the HER2, if there's a tumor cell next to it that doesn't have HER2, it will leak out of the dead tumor cell and kill that one as well. That's called bystander effect. And so it's so important to have a drug that has bystander effect like that, because then it works even if you have low HER2. So if you do a HER2 test and you find that your score is only 2+ and you don't have the full 3+, you can still do this drug because it will still work. It won't work as well as if you have a 3+ score, but it will definitely work. And they're finding out now that this drug, TDXD, actually even works in women that have HER2 0. So, you know, it's quite an exceptional drug. So this drug had, on August 31st, it had one of the first FDA designations. And this designation is called agnostic approval. And agnostic approval means it's not approved for one type of cancer. It's approved for any type of cancer that has high HER2. In other words, it's a precision oncology approval. It's based on the mechanism, not the location of the cancer. So once again, precision oncology looks at the mechanism, not the location. Here's an example of a patient, brief example that we saw, a 60-year-old patient with high volume metastatic prostate cancer. He initially received ADT, docetaxel, but progressed. He was given 6 additional lines of therapy, 6, which elicited transient responses, followed by rapid progression. So this individual had a very high Gleason scale, probably a Gleason scale of 9 or so, a very aggressive cancer. He also developed a brain metastasis and had a craniotomy with tumor resection followed by radiation, which is just buying time. So his doctors said, you know what? Let's find out why this individual's cancer is so aggressive. So they took a sample of his tumor from his brain, and they found that it had transformed into this neuroendocrine prostate cancer that I discussed that earlier. It was one of the ones that's resistant to standard prostate cancer treatments. And they'd found that it had transformed into this neuroendocrine subtype. And that's a very aggressive subtype, even in the context of metastatic castration-resistant prostate cancer. So when they did HER2 testing on it, they found that he had strong expression in both the primary prostate tumor and the brain metastasis. So they gave him 4 cycles of TDXD, 4 injections. There was immediately a 57% overall reduction in tumor volume across all sites, including the brain. And it even stabilized his bone metastasis. And then the blood counts, lactate dehydrogenase levels, and so on, the standard blood work that doctors usually do, and his performance status all improved, despite being recommended for palliative hospice care several months earlier. So this guy had his life back. He was given a couple months in palliative care to survive. And one simple test that was fairly cheap, IHC is fairly cheap, it's about $1,000 or so, changed his life. So what we do now, there are probably these antibody drug conjugates, there's many of them, not just for HER2. There's a whole bunch of new surface cell receptors we found now, folate receptor alpha, TROP2, PVRL4. There's a whack of different cell surface receptors that now have FDA-approved antibody drug conjugates. In fact, we see a new one every month that gets approved. And so what we do now is, instead of just testing prostate cancer patients for HER2, we test them for all of the potential antibody drug conjugates that are available that are FDA approved. And so we don't just use, so that would be right now, I think there's this, I can't keep track of this, but last I heard is there's probably about 25 different antibody drug conjugates approved, all for different things. And so when we test people for these antibody drug conjugates to see if they have the cell surface receptor that the antibody drug conjugate targets, we usually find about 5 or 6 of them for every patient. And so those patients can do those sequentially. So even if it's not HER2, it may be TROP2, it may be PVRL4, it may be, a variety of different receptors. So the problem is if you want to get your sample just tested for one thing, you could use up the entire biopsy sample just testing for one potential clinical trial or one potential antibody drug conjugate. So what we recommend is we have a test called the RNA expression test where we look at 20,813 genes. So that covers all of the antibody drug conjugates available now and all of the ones in clinical trials and all of the ones that will ever be invented. Because 21,813 genes is almost all of the genes that we have. So this is a great test, and it tells us all of the different potential treatment options, how to get into, tell us which clinical trials are going to work for people, which ones are not, and which ones of these antibody drug conjugates are going to be beneficial or not. We have a bunch of educational videos, including videos on antibody drug conjugates. This is one on our RNA expression panel. We've only had this panel for 2 years, but since we've had it, we literally have not had a patient that we have not been able to come up with amazing new technologies and treatments for. It's just been a game changer. And we got one more slide. Just wanted to share that we do one-on-one consultations, and we could go over your medical records with the team and so on. And so if you want to go to our website and look up that, then it's right there.